So welcome back, and thank you to everybody who's joining online and from home. And I'll just remind you that you can put questions into the chat, and we have people monitoring that as well. I was having some nice discussion with people in the chat as well, so it's very virtual, very 2021. My name is Elizabeth Donner. I'm a pediatric epilepsy doctor, and I work at the Hospital for Sick Children in Toronto. I'm also a co-chair of PAME. Thanks to Jeff for a great history of PAME this morning, reminding us where we've been and a little bit about where we're going. We are going to start this session with another video. We have some really powerful videos today, and I can ask that get keyed up.
We need to talk.
We need to talk.
I'm Anu Patel. I'm the Section Chief of Neurology here at Nationwide Children's Hospital. SUDEP is sudden unexpected death from epilepsy. And basically, it's when a person who has epilepsy dies and is associated with an epileptic seizure. It's overwhelming, right, when you hear the first time about SUDEP as a patient, a caregiver, or even a medical provider. But then you can learn and use that information to help improve your opportunities to decrease that risk. And that's really what it's about.
My name is Michael Privatera. I'm director of the Epilepsy Center at the University of Cincinnati Gardner Neuroscience Institute. Talking to patients about SUDEP is really often a challenge. I think one of the most difficult things is when do you start talking about it? But I think it really is important at some point to get it into the conversation of every person with epilepsy. People with seizures have to understand that if they don't do everything they can and work with their doctors to try to minimize the number of seizures, they are at risk for SUDEP.
I'm surprised by the number of patients that come to my office as a second or third opinion that have never heard about SUDEP.
The physicians need to know that patients want to know. Patients have been very clear that we don't want this risk of SUDEP to be hidden away from us. We want to know about it, and we want our providers to tell us about it, and we want our providers to work with us to help reduce the risk of SUDEP. When patients understand all the risks of the disorder that they have, I think it helps.
If we don't talk about SUDEP, we're going to miss the opportunities that we could have done together to help lessen your risk of it.
The more we learn about SUDEP, the more people can feel empowered.
The Epilepsy Foundation of America has a lot of excellent materials and educational tools that help you as a patient or a loved one that cares for someone with epilepsy understand SUDEP and your risk of SUDEP. So I always believe knowledge is power, and I think knowledge on this space is absolutely important. We need to talk.
We need to talk about SUDEP to end SUDEP.
Thank you, and thank you to EF for those videos. Super powerful, and it's really wonderful for me to hear leaders in the field and leaders in the pediatric field, which is close to my heart, advocating for SUDEP discussion at the same time as we just, an hour ago heard the Perry family remind me that we're not really there yet with everybody doing the talking we need to. It's been really through amazing advocacy that it's brought us to the point where talking about SUDEP is at least an expectation, even if it's not being done. I think I remember vividly the experience of going to meetings and presenting about SUDEP and advocating for SUDEP disclosure, and inevitably there was someone in the crowd, a physician, who would stand up and tell me I was wrong and why we shouldn't talk about SUDEP and the harm we were doing by talking about SUDEP. And the message that I have for families like those who are here with us today and sharing their stories is that that doesn't happen anymore. So I know we're not where we should be, but it is no longer kind of acceptable for a physician to stand up in a crowd and say we shouldn't talk about it. And that doesn't mean we're far enough, but I do think we're making progress, and I'm encouraged by that. So moving on to the current session, We have spent a lot of years working in the Sudep field, defining Sudep, and we've just heard some amazing progress in foundational science, expanding our understanding of Sudep mechanisms, Sudep biomarkers, and so now we're going to turn to our discussion around how best to study Sudep in people. Are there ways that we can improve our surveillance of Sudep to unmask risk factors? Can those risk factors help us define high-risk populations more appropriate for study? And are we yet at a place where we can actually develop intervention trials for Sudep? I think it actually dovetails really nice from our last session. So with that in mind, I have invited 3 speakers to consider best practices for studying Sudep. Commander Sharyn Parks-Browne holds a PhD in MPH, is an epidemiologist with the CDC and the senior epidemiologist and data manager for the sudden unexplained infant death and sudden death in the young registries. And she's going to talk to us about how best to use registries to study premature mortality. And Dr. Parks-Browne is joining us virtually, presenting a live presentation. Then we're going to hear from Dr. Zach Grinspan. Thank you for being here in person, so I'm not lonely on the podium, who is an associate professor and interim chief of child neurology and director of pediatric epilepsy at New York Presbyterian Weill Cornell Medical Center in New York City. He leads several monthly center initiatives utilizing electronic health records and big data and multiple cycles of data collection to address epilepsy in children. Finally, we will have a third virtual presentation from Professor Philippe Ryvlin, who is a professor of neurology and chair of clinical neuroscience at University Hospital of Lausanne, Switzerland. Philippe has published several landmark papers in the field of Sudep. We've already heard some of his work referenced today, and he really is one of the leading thinkers in this field, and he's going to speak to us about planning intervention studies for Sudep. So thank you for joining. We're going to get started with Dr. Parks-Browne. I have no idea how to make that happen. I'm hoping the guys in the back of the room can do that.
Are you able to hear me, Elizabeth?
I can hear you. Oh, that's so exciting. Thank you.
Oh, great. Can you see me?
We can hear you. We can see you. It's perfect.
Excellent. Okay, so shall I take it away? All right, well, good morning, everyone. Thank you for having me. Is the sound okay? I hear a little bit of an echo, but if it's okay in the room, I'll continue.
Is it clear to people? Yes? No? It's a little bit.
All right, well, hearing no comment, I'll go ahead and proceed. I do want to thank you all for having me. I'm really delighted to be able to join you for this session as a first-time PAME attendee, and I do apologize that I'm not able to be there with you in person today, but we're still under really strict travel restrictions as federal employees. But today I'd like to share our experiences with conducting surveillance on sudden unexpected infant death in children and infants through CDC's Sudden Unexpected Infant Death and Sudden Death in the Young Case Registry, with the idea that our experiences may help advance our understanding and hopefully prevention of epilepsy-related mortality. So throughout this presentation, I'll be using the term SUID for sudden unexpected infant death, and I'll refer to sudden death in young as SDY. And I'll also refer to the SUID and SDY registry collectively as
Sharyn,
the
it's a little bit
registry.
muffly. I don't know. I'm not 100% sure why, but if you can speak maybe a little bit clearer.
Okay, is this any better? I can hold my microphone closer.
Yes, that is better. Thank you.
Okay. All right, before I dive in, I do always have to start with my CDC disclaimer that the findings and conclusions that I'm presenting here are mine and mine alone and do not represent the official position of CDC. So to begin with a bit of background on the registry, it's a population-based surveillance program that's operating in 17 states and 5 jurisdictions. It was built upon the Child Fatality Review System and in close partnership with our colleagues at the National Center for Fatality Review and Prevention. So all of our awardees use the National Center's protocols, their multidisciplinary team structure, review the same types of records, including medical records and those from death investigations. And the data are recorded actually in the National Center's web-based case reporting system. The overarching aim is to have all sudden unexpected deaths that occur in the participating jurisdictions reviewed and to ensure that quality data are consistently compiled on all of those deaths. We then use that quality data to determine incidents and to increase our understanding of trends and characteristics of various types of deaths, and hopefully to identify causes and risk factors when we can. And then finally, we want to use data from that process to drive improvements to investigations and ultimately inform prevention strategies. So we began this endeavor back in 2009 when we funded our first 7 states for 4 years of surveillance for SUID. No, get ahead of myself. We were then able to release our second round of funding in 2012 and increased our surveillance up to 9 states. And as all of that was happening, in 2010, a working group at the National Heart, Lung, and Blood Institute, or NHLBI at NIH, developed a research agenda for the best approaches to reduce sudden cardiac death in the young, including developing a prospective registry to gather incidence data and identify risk factors. But because of their interest in supporting research and epidemiology of SUDEP, NHLBI reached out to the National Institute of Neurological Disorders and Stroke, or NINDS, to participate and co-fund the SDY registry in partnership with CDC. So in 2015, the SUID case registry was expanded to include the SDY component, which expanded surveillance to include adolescents, children and adolescents up to age 18 who died suddenly and unexpectedly, including those that were due to cardiac causes or epilepsy. So through the support of our NIH partners, we were also able to increase the number of awardees participating in the registry to 18. So we doubled the size. So here we are in our current funding cycle, which includes SUID and SDY. We've got 22 states and jurisdictions that are funded, and we're capturing about 30% of all US SUID cases. In addition to the surveillance efforts of our registry awardees, since December of 2016, NHLBI has been funding several independent researchers to conduct research on biospecimens obtained through the registry as well. So the researchers from Northwestern, Vanderbilt, and the University of Utah are working collaboratively to do genome sequencing, and they're focusing specifically on cardiac and epilepsy genes. And to date, they've sequenced 212 genomes and are planning to publish results from that work in early 2022. So that's really exciting. So just to talk a little bit about our case process. When an SDY case occurs in a funded state or jurisdiction, a pathologist identifies the case as an SDY. They complete a thorough autopsy, and then they have a biospecimen that's saved for DNA extraction. Each case is then reviewed by the child death review team with the purpose of documenting case information and making prevention recommendations. Then each case is reviewed by an advanced review clinical team that consists of pediatric cardiologists, neurologists, often a pathologist, and a genetic counselor as well. And the purpose of that group is to categorize each case based on the most likely cause. Then at the awardee level, the data are used to calculate incidence and identify prevention activities. And then finally, the data and DNA samples are used in the research phase that I just mentioned a moment ago. In terms of cases that are included in the registry, we have 2 case definitions. So for SUID, we include infant deaths that occur suddenly and unexpectedly, where the cause is not known immediately before an investigation. They have to be residents of the state reporting the death, and we exclude intentional homicides. So typically these are cases where the death certificate includes things like unknown, undetermined, SIDS, or SUID, and a number of other causes that I've listed here. Then for SDY, the case definition is a little bit broader. So here we're looking at infants and children up to age 18. Again, they do have to be residents of a funded jurisdiction, but they still have to be deaths where it was both sudden and unexpected. And we also have a few more exclusions that are applicable to older children. So in addition to homicide, we're also excluding suicides, intentional overdoses, terminal illnesses, and obvious injury-related deaths. All cases in the registry are categorized using an algorithm that was developed specifically for the registry, and that uses strict criteria to determine the most appropriate classification for each case. So this process promotes standardization of case categories that then enables us to better track trends in these cases. So here you can see the 4 broad groups that cases are categorized into. The explained causes include explained cardiac, explained other causes, or explained infant suffocations. The unexplained possible group includes those that are ultimately categorized as possible cardiac, Sudep, or possible cardiac, and Sudep. The unexplained group includes the categories of unexplained infant death and unexplained child death. And then lastly, there's the unknown group. And these are cases where usually there wasn't enough case information for our advanced review teams to categorize the case. And then there's a few cases where after review of all the case information, the advanced review team determines that they were due to some other known cause. So now I'd like to share with you some of what we've learned using case registry data so far. In 2020, Dr. Kristen Burns, our colleague at NHLBI and also a fellow SDY Registry Steering Committee member, published a paper called The Epidemiology of Sudden Death in a Population-Based Study of Infants and Children. So this study sought to characterize the causes of sudden death in young and calculate mortality rates. We used data from 8 states and jurisdictions in 2015 and 9 states and jurisdictions in 2016. So this is from the early years of the SDY registry. We did calculate mortality rates using live births as the denominator for infants, and then using census data population rates for the denominator for children. Then we calculated mortality rates for children and infants separately. And to protect privacy, we do not report data on cells with counts less than 6. So from that study, we found that 3% of SDY cases were categorized as Sudep, and another 1% were categorized as possible cardiac and Sudep. And this next slide is just a more detailed view of the data from that paper. So among the little over 1,300 SDY registry cases in 2015 and 2016, again, we had about 5% of the total cases were unexplained Sudep. And these were cases for which there was a history of a diagnosis of epilepsy or seizure disorder with or without evidence of seizure at the time of death. And we also identified 12 cases as possible cardiac and Sudep. And again, this was about 1% of all of the cases. And these were ones where there was a diagnosis of epilepsy or seizure disorder again. And while there was no clear cardiac cause identified, one of the following was present. So either these children had a family history of potentially fatal heritable cardiac conditions or sudden death in a family member before age 50. They may have had a personal history of cardiac disease, or the story from the circumstances surrounding the death made it suspicious for a cardiac death. So here I have a breakdown of the various categories for infants. This is how cases were categorized by the advanced review teams in the registry. We've got the causes for infants on the left and for children on the right. And you can see differences in how the categories are distributed. So for infants, the majority of cases remain unexplained. So you see 54% of them are categorized as sudden unexplained infant death. And then for children 1 to 18, the largest group of cases, 48%, were due to explained other causes. And then another 20% were due to explained or possible cardiac causes. And then this is just another depiction or summary of that for folks who are more visual. And you can see almost opposite proportions of explained and unexplained causes for infants on the left and children on the right. And regarding some of the descriptive data examined and reported in that same paper, we found that 72% of SUDEP cases occurred during sleep or rest and were not witnessed. And then only 69% of SUDEP were autopsied, compared with 92% of SDY overall. I also wanted to share another analysis of registry data from last year. So this one was done by Vicki Whittemore, our colleague at NINDS, who's also one of our registry steering committee members. And she actually reported this data from the registry at the American Epilepsy Society meeting last year. So some of you all may have seen this presentation. But Dr. Whittemore provided some additional characterization of SUDEP cases in our registry. Specifically, that 73% of SUDEP cases were between 0 and 14 years of age, with an incidence of 0.26 per 100,000 infants and children. And also, interestingly, revealed some racial disparity in incidence. So compared to the 0.26 per 100,000 overall, the incidence was 0.22 among white infants and children, and it was 0.32 among non-white infants and children. She also concluded that potential factors to be explored further using registry data or other data available to us include looking at socioeconomic status and access to care issues that may be resulting in poor seizure control. And I'm happy to say that Dr. Whittemore is also working to publish these findings as well. So this may not seem as relevant, but as I've already shared, the SUIT component of the registry began in 2009 as compared with the SDY expansion that didn't happen until 2014, so 2015. So in addition to having more years of data for SUIT, we've had a lot more time to work towards implementing programmatic practice and even policy changes in association with our data. So here's some examples of things that have come out of the collection of data on SUID. So we've had a number of hospitals that have put in place safe sleep crib cards in the nurseries and even in patient rooms, just to help remind people about what safe sleep looks like for newborns. We've had some of our awardees do combined safe sleep and shaken baby information into an All Babies Cry program that provides suggestions for safe ways to soothe a crying baby and get them to sleep safely. We've had an awardee that was able to drive amendments to rules that are regulating childcare centers to ensure that they're incorporating safe sleep practices in the childcare setting. Some have done training with CPS, social services workers, EMS workers, and even training workers in the local housing authority maintenance crews. So when they're going into apartments and they see that there's an infant and they're looking out to see if there are safe sleep locations within a particular apartment. And if not, they connect them with services to make sure they can have a pack and play or crib in their house. And there's a couple other examples here. Another one just to highlight is one of our awardees worked with dollar stores and Babies R Us back when they were still open to put in floor talkers that talked about safe sleep messaging. So as folks were doing their shopping for their infants, they were getting that safe sleep messaging. So just again, sharing these to represent the types of things that can hopefully be accomplished with the SUIT and SDY registry data for SUDEP and other causes of death in the future. One last key part of our work with the registries that I wanted to emphasize has been the use of registry data to highlight areas for improvement and the medical legal investigation process for children and infants, particularly around death scene investigations. So one of the best standardized tools to help guide infant death investigations right now is the Sudden Unexplained Infant Death Investigation Reporting Form, or SUDERF. So the SUDERF was developed in 1996 through a collaboration between CDC and a group of external experts, including folks from the National Association of Medical Examiners and other experts in the area of SIDS and sudden death. It's now been updated twice, once in 2006 and just last year. And each time, again, it was through extensive engagement with external stakeholders and end users. And this most recent update, we're able to look at case registry data to see where detail from investigations could be improved and allow that to guide the revision process of the form as well. And the success of the SUDERF actually helped drive the development of an SDY field investigation guide and family interview tool for use with children over 1 who die suddenly and unexpectedly. And prior to the development of this form in 2017, there was no widespread or standardized format for conducting investigations into these deaths. So that resulted in a lot of variability in the quality and quantity of data collected. So to give you an idea of the data elements contained in these guides, the SUDERF is a 12-page document with sections on demographics, witness interview, as well as the infant's medical history, the mom's pregnancy history. There's section for detailed investigation summary and diagrams. The pathologist has a summary, and then there's detailed incident scene investigation. And then the SDY tool is a 6-page document that can be used alone for older children or as a supplement to the SUDERF for infants. And it has sections, again, on demographics, witness interview, but it also has a lot of detailed information on activities of the child within 24 hours of the death, whether there were any resuscitation attempts, what was going on with the child's history or with their symptoms prior to 72 hours before death, detailed child and family medical history, and then any epilepsy history if it was if the child had a prior diagnosis. So both of these tools can be used in a number of ways. They can be used during the actual death investigation as a guide to ensure that all of the pertinent information is collected. They can be used by pathologists or other death certifiers in determining the cause of death, because they've got a ton of variables here that they can help use as evidence. And they're also often used during the multidisciplinary child death review process. And each of these serves to help improve the quality of data, which we can use to continue advancing our understanding of SUID and SDY. In terms of where we go from here with the registry, FY22, so our current fiscal year, is the last year in our current funding cycle, and we're anticipating releasing a new notice of funding opportunity in FY23, through which new awardees can be funded, and hopefully we can expand further. And there's also a research funding mechanism for understanding sudden death in the young available through an NIH Notice of Special Interest. So for this, studies funded through this mechanism are required to use the data and DNA samples from the registry as foundation for the research. And this notice opened in October of 2020 and does not close until January of 2023. And lastly, I wanted to mention that as we're compiling and analyzing all of these data, we also welcome others to use these data, because we honestly feel that the more heads we have looking at the data and trying to tease apart the puzzle of SUID and SDY, the better. So all of the variables that populate the case registry are included in the National Center for Fatality Review and Prevention's database, and thus available through the center's centralized data request process, which allows researchers to apply for and receive de-identified data for use in their independent research. So I'm just showing a screenshot here of their website. It's ncfrp.org, and that's where folks can get information on accessing the data. With that, I just want to thank all of our collaborators, as well as the families that participate in the registry. And I guess I can turn it over to the next speaker or take questions depending on how our moderator would like to run things. Thank you.
Thank you very much, Dr. Parks-Browne. We are going to have a panel discussion at the end, so I'll ask you to hold tight, listen to the rest of the speakers, and then we'll pull you up on our screen at the end of the session or towards the end of the session. And so now I'll invite Dr. Grinspan up to proceed with his presentation.
Thank you so much. Thank you to the organizers. Actually, I want to give a special shout out to Jeff Buchalter, who is very convincing when you talk to him about your practice and has changed my practice around Sudep counseling. I also want to give a shout out to Gardner Lapham and Dr. Elizabeth Donner for organizing the conference and for inviting me to speak. The Band Foundation also gets a big shout out for funding the work that I'm going to talk about. So my name is Zach Grinspan. I direct the Pediatric Epilepsy Program at Weill Cornell Medicine in New York City. This is my funding. These are some additional disclosures. But the premise of what I want to talk to you today is about how can electronic health records help us understand mortality in children with epilepsy. And so to address that topic, I'm going to talk about two different things, though they're related. One is the Pediatric Epilepsy Learning Healthcare System, and then the second is something called the Pediatric Epilepsy Mortality Initiative. So let me start with the first, the learning healthcare system. This idea of a learning healthcare system is really exciting and gets at something that we all think should be happening in medicine, but hasn't for a variety of reasons. The idea of a learning health system looks like this. You take care of patients, you look to see how they did, you learn something, and then you change your practice. And you do that again and again in virtuous cycles and watch as your outcomes continuously improve. It sounds so easy and so obvious, but we've had trouble doing this in medicine. One of the organizations that is quite inspiring and has done this well is a group called Improve Care Now. They're pediatric gastroenterologists. They take care of children with Crohn's disease and ulcerative colitis. They got together 12 or so years ago and decided to improve outcomes for their disease. And their results were astonishing. When they started, the remission rate for their disease was about 50%. And within a few years, they were up pushing towards 80%. I think this is 5 years on this graph, and they're now well past 80%, now towards 85%. So based on this, we got very, very excited to try to do the same in epilepsy. I'm talking about one learning healthcare system effort, the Pediatric Epilepsy Learning Healthcare System. But I do also want to give a shout out to a parallel and aligned organization, the Epilepsy Learning Healthcare System. They call it ELLIS, that's run out of the Epilepsy Foundation. That organization is all ages. We're more focused on children, but we're working together to bring this vision of these cycles of improvement to the epilepsy world together. The Pediatric Epilepsy Learning Healthcare System, our mission is to reduce seizures and their consequences for children with epilepsy through cycles of health data collection and analysis, dissemination of new evidence and practice change. And our vision is that all children with epilepsy receive timely and optimal care according to standards that are continuously improved. I'm leading the effort and have just an amazing group of collaborators that are leading this with me. Dr. Patel, who you saw earlier on the video, Dr. Berg, Dr. Schellhaus, and Dr. Buchalter, who many of you know. Our organization is off to the races. We have 25 centers. We have data from 18. It allows us to put up these big numbers about how much data we've collected. We're doing the academic thing, as is our mission, and publishing papers about some of our findings. The way that the system works is that each site in the eventual vision sends us data in 3 buckets. There's sort of 3 flavors of data that we're chasing. The first is in many ways the easiest. Every time you go to see a doctor, all this administrative data is collected. Your name, your date of birth, what diagnosis you have, what medications you're on, what procedures you get. So that data's there, and you just have to find the right person and figure out how to get it out of the system, export it, and then into your data coordinating center. And that's where we focused a lot of our work. We're very interested and on our way to collect the data that's probably the most important, which is the clinical data. Is this child still seizing? Why are they seizing? Why do they have epilepsy? How is their life? What is the quality of their family's life? So we're actively working on disseminating tools to help collect that data at the point of care. And then there's also a bunch of data, for lack of a better term, I'm calling the fine phenotype data, the images, the EEGs, the genetic data, et cetera. We know how to get that out. It's just expensive. So you need to have an army of research assistants at all of your sites pulling this data and sending it in. Our idea is that this kind of data could feed 6 areas of inquiry: quality improvement, comparative effectiveness, surveillance and epidemiology. That's bolded because of our work in mortality, health services research, clinical care, and clinical trial infrastructure. And then again, what makes it a learning healthcare system is that whatever you learn, you send back to the sites in cycles to continuously improve. I'm nerding out a little bit just to give you a little bit of details of kind of the nitty-gritty of how this works. Each site sends us these big files of data. We crunch it, find patients that we're interested to know more about, and then send those lists back to our sites. They review the charts to find the information that we don't have in our electronic record data. And then send that back to us again, and then we crunch the data now that we have a full data set and send it back. The reason I'm talking about this at this conference is that one of the pieces of data that we get from the electronic health record is date of death. And so we're sitting on 18 centers worth of dates of death of people, of children who we know have epilepsy. And we couldn't sit on that. We had to do something and learn from that data. It was actually quite sort of compelling, deeply compelling to take that data and make use of it. A final word just to flesh this out. One of the things that we did is we sort of, for lack of a better term, jury-rigged the electronic health record systems in order to get some structured data about children with epilepsy. And this is, I don't know if this will play. If I click play, will it play? It will. And I'm showing off a little bit because it took us like 4 years to get this built. This is Epic, which is one of the electronic health record systems. We worked with the vendor, this huge multinational company, to build a form specific for children with epilepsy. We worked with parents, we worked with advocates, we worked with PhD researchers and clinicians from around the country to figure out what are the questions, what are the choices, what are we going to ask. This is that form. And then the doctors were like, we don't want to be clicking all these buttons during our visits. And so we said to them, okay, we're going to figure out a way so that when you click the buttons, the data gets sucked into your note so that you're actually more efficient in clinic. And so what's happening now are like you do a dot phrase for doctors who use EHRs, you use a dot phrase and all that data gets sucked into your note. We're disseminating this. I think there's a total of 13 sites in the US that have this installed in some way in one of their EHRs. And now our work is to try to convince people to use this. Okay, so that's the foundation. And remember, we're using this to get dates of death. So based on the system, we said, let's use this to learn about mortality in children with epilepsy. And that's the Pediatric Epilepsy Mortality Initiative. So we wrote a grant for this, and these were our aims. I'm putting the aims here to kind of show how we're imagining this whole initiative is going to work. Aim 1 was to identify, characterize, and review deaths. Aim 2 is to try to get some interventions and monitoring going. And then aim 3 is to learn and to teach both ourselves and everybody else whether what we're doing is working and valuable. So I'll go through each of these aims in a little detail to teach you today about what we've been up to. When we thought about identifying and characterizing and reviewing deaths, that paper by Dr. Davinsky, Dr. Friedman, and their colleagues really resonated with us. You've seen that slide, I know in Dr. Buckhalter's talk and some other talks. We've taken this and we've kind of thought about it a little more and modified it to some extent, added a few rows, added a few concepts into it, although we've kept the overall structure the same. In listening to some of the talks today, what I'm realizing is that there's an alignment issue that we're going to all have to figure out, because as we collect data, we're going to have to make sure that it speaks well to everybody else's data about causes. The second thing we did, that first taxonomy, can I go back, was about cause. But one of the things that we're doing as physicians, as we collect data for this initiative, is that we ourselves, as the physicians, are looking at these charts, and it's really uncomfortable and painful as a physician to review the story of a child who you've lost. And in that process, there's a lot of second guessing and doubt that a physician will have. We wanted to capture that because it's important. We wanted to have that woulda, coulda, shoulda, those cycles of doubt, and we wanted to say, well, look, if you could play that again, if you could play the retrospectoscope and go back in time, what would you have done differently? And so we've created a list of some things we could have done differently. Interestingly, we were going to try to collect this at the individual patient level, and many of our colleagues pushed back and said, look, woulda, coulda, shoulda is important, but also a legal risk. So don't ask us at the individual patient level. So what we're going to do is we're going to collect this in the aggregate, and we're going to look at these and sort of say, okay, you looked at a bunch of cases. Now, having reflected on that, what do you think is most important? And roughly, there's sort of two groups, three groups, I guess, of things. Are there different things you could have done at the time of visit? You're the doc, you're in front of the patient. Would you have done something differently? And then the second is from a healthcare delivery standpoint. Could we have created systems of care that would do something differently? The third bucket is linking to the bench scientists and the clinical scientists that we heard from. Are there opportunities for discovery specific to the cases we reviewed that we think could help move the needle and reduce mortality? Okay, I have some data. That's like the most fun thing to talk about at conferences like this. I guess that's a strange word to say at a mortality conference. My apologies. Sorry. So this is what we've done. We were able to collect data at 17 sites. There's 500,000 individuals, 45,000 dates of death in this data set at 17 sites. We said, okay, just to get us started, let's look at people who are under 25, and at each site, look at the 20 most recent deaths. And we were able to get these lists out to 12 of our sites. We're still working on data quality for many of our sites. As I put this talk together, we had data from 99 cases. And so, those numbers are still small, so this is still preliminary. 99 at 7 of our sites. And of those 99, 15 of them had acute symptomatic seizures, 59 truly had epilepsy, and 24 did not have epilepsy or seizures. They were either miscoded or had an epilepsy or seizure diagnosis for something else. And this gives a sense of kind of the accuracy. We went from, about 60% of our reviews led to a child with epilepsy. The age distribution was sort of interesting. The acute symptomatic seizures tended to be younger than the children with epilepsy, which had a broader distribution. The other thing, again in preliminary data, is that the average age of the decedents in our data were younger than the general population, giving us some early insight that we should be focusing on early life epilepsies in our quest to reduce mortality. Here's some details of these 59 decedents. The average age was about 9. only 40% female, most white, 10% black, and 12% Hispanic. A mix of focal, generalized, or combined epilepsy, 60% treatment resistant, not all of them, 60%. Almost all had established epilepsy for more than 6 months. 78% of them were non-syndromic, meaning that we didn't have a specific syndrome to assign to them. 19% Lennox-Gastaut syndrome, and 3% early infantile epileptic encephalopathy. Half had a clear history of generalized tonic-clonic seizures. And what's interesting about that is that it's only half. We think about GTC as this big risk factor, and certainly if it's there, it raises your alarm. But half did not have that history, emphasizing the importance of counseling. 10% had had a GTC on the day of death, and 5% had a history of GTCs in sleep. 12% had an episode of status epilepticus in the past year. 75% had a known reason for epilepsy, 60% had an abnormal MRI, and 40% had a genetic etiology. And then comorbidities, many had. 83% had developmental delay, half intellectual disability, half cerebral palsy, 17% with visual impairment, and then 44% with a gastrostomy, 30% with a wheelchair. So a significant proportion of disabled children with technology dependence. Some other details. Many had some recent care in the month before death, suggesting the electronic health record is going to be a potentially valuable source of information for them, though 40% had no information. Counseling, we looked to see if there was any evidence in the year prior to death for counseling in a variety of areas. Only 3% had documentation of SUDEP counseling. Didn't mean it didn't happen, but only 3% of the time for these 59 cases had someone written in the chart that they had done it. There were also low rates of anxiety and depression counseling in the children, 0 about driving risk. 44% had talked about rescue medicine. Only 2% discussed nocturnal supervision. And of all of these kinds of counseling, 42% of these children had no documentation that any of the counseling had occurred. Place of death, half were at home. 14 of those were unexpected, but 16 of those were in hospice, and about a third were in the hospital. And the cause of death was very varied. About 14% directly due to epilepsy. There were 5 examples of sudden unexpected death in this data set, and 2 had been reported to Nasser, but not the other 3. 2 were due to status, 1 drowning. 3% medical or surgical complications of care, 25% to an underlying condition, 22% unrelated to epilepsy, and a significant portion, a quarter, we just really couldn't tell, which I think highlights both the promise and the perils of this data source. So things we're working on, we're trying to send out to get death certificates from and to do an NDI query. That's still in progress. Aim 2 in the grant is to think about interventions and monitoring. I'll go through this a little quicker. SUDEP counseling, this is critical and important. In our form, there are some questions that ask about important SUDEP risk factors. Are you having generalized tonic-clonic seizures? Are they happening at night? And then at the bottom of the form, there's a button that shows up for every visit. Did you discuss SUDEP? Yes, no. And it's a little small, but there's a little triangle with an exclamation point saying, like, this is important. Anxiety and depression are also important, and so that shows up. I think it's like either 5 or 7 or older, to make sure that we're prompting ourselves to screen for mental health comorbidities. That's important given that suicide is an important source of mortality for children with epilepsy. We also want to make sure that children who have refractory epilepsy get seen by epilepsy specialists. One of the important things there is like, well, how do you find them? At a health systems level. And so we've done some work thinking about what are the codes that we can find in the EHR and what's the right combination of codes. So we've got 2 publications on this. We think we know how to do it, and now we just need to deploy and do the work. Our to-do list is still long, so I'm hoping, if I'm invited back, to update folks on this project. We're still working on improving the access to home rescue medicine. We want to make sure that we're counseling about nocturnal supervision. And then I can check the box. This is sort of our first dissemination activity of our findings, but we hope there'll be more. Thank you all for listening.
Thank you, and thank you for letting PAME be one of your first dissemination. We're very happy to be your KT AIM checkbox. That's great, thank you. And I have questions that I will hold as well until we have heard from Dr. Ryvlin. So we have a pre-recorded talk from Dr. Ryvlin that I will ask our AV colleagues to pull up and start, and then we can do a panel discussion.
Dear colleague, I wish to apologize for not being able to be on site with you today, but I'm really grateful for being invited by the PAME organizer and Elizabeth Donor for sharing with you my thought about how to plan intervention study for SUDEP. This is quite a challenging endeavor, for which I'd like to discuss four main issues: which intervention, which primary endpoint, which population to recruit, and which trial design. Let's start with the types of intervention. I think it's important to distinguish two different types of intervention. Those that correspond to anti-seizure treatment, some of which seems to have some anti-Sudep property. Whether or not it's related to the level of seizure control, and that includes some anti-seizure drugs, neuromodulation therapy, and epilepsy surgery. On the other hand, we have some potential anti-Sudep treatment that are not being used for controlled seizure, even though they might have an impact on seizure control, hopefully a positive one, like what is sought for serotoninergic agent. But there's also risk that some of those anti-Sudep treatment, like those acting on adenosine, could have a negative impact on seizure control. Those anti-seizure treatment include nocturnal supervision, a number of pharmacologic agents that will target the so-called SUDEP biochemical cascade, but also devices that could be used either for repositioning the patient after a generalized tonic-clonic seizure or for resuscitation if needed. What is the rationale for considering these two types of treatment? And let's start with the anti-seizure treatment. Well, we have some low, sometimes moderate quality evidence that suggests that some anti-seizure drug, for instance, levetiracetam, that are associated with a lower risk of SUDEP as compared to the other anti-seizure drugs. This comes from a recent nationwide case control study performed in Sweden, probably the most compelling data that has been collected so far through case control study. And so, of course, it's not a randomized trial, but in that study, LEV proved to be associated indeed with a lower risk of SUDEP as compared to the other drugs. There recently, Ellen Cross has published an important paper showing that fenfluramine, on top of being very effective in controlling seizure in Dravet syndrome, is associated to a very low risk of SUDEP as compared to what is usually observed in that syndrome, and so suggesting that it might reduce the risk of SUDEP. Some years ago, we have shown that when pooling randomized controlled trial of add-on anti-epileptic drug as compared to placebo, the former was associated with a 7-fold lower risk of SUDEP than the later. The same case control study I mentioned, performed in Sweden, showed that patients who were treated with vagus nerve stimulation had significantly lower risk of SUDEP than those who were not. And we had previously shown that this decrease in SUDEP risk appears to increase with the duration of treatment. And finally, there are some evidence, disputable, but some evidence that epilepsy surgery is associated with low risk of SUDEP. Why should we study those issues further? Well, I think it's important that we demonstrate whether or not those anti-seizure treatment are effective in reducing the risk of SUDEP as compared to other treatment options, and also to quantify the magnitude of this impact, because that could lead to changes in guideline and recommendation regarding epilepsy care, and that might translate in a significant reduction of SUDEP incidence overall. What about the anti-Sudep treatment? What evidence do we have to test this or that intervention? Part of the rationale derived from our observation of Sudep recorded in person undergoing video EEG recording in EMU. And that showed that most Sudep seems to be related to a postictal, post-GTCS, neurogenic apnea. And from what we know from the pathophysiology and physiology of respiration and experimental studies in different animal models, this neurogenic apnea might be promoted by altered monoaminergic activity, as well as a postictal release of maybe an adenosine, maybe endogenous opiate, and also spreading depolarization within the brainstem. And all those elements might in fact be related to each other. There are indeed experimental studies in rodents showing that monoaminergic and adenoninergic agent lower the risk of seizure-induced respiratory arrest and SUDEP. And maybe most importantly, to tackle this hypothesis, we have available drugs that prove to be overall very safe and well tolerated in millions or tens of millions of patients suffering from other conditions, and that could then be tested in person with epilepsy with very limited risk. And on top of that, this treatment could have secondary benefit. SSRI, NSRI could also tackle comorbid depression and might have some anti-seizure potential. Atomoxetine, a norepinephrine recapture inhibitor, is effective against ADHD and potentially comorbid ADHD in epilepsy. Naltrexone, which is an antagonist of endogenous opiate receptor, has been widely used against alcohol dependence, which is a comorbid condition in epilepsy that proved to be a SUDEP risk factor. And finally, caffeine that block adenosine, or genistein, who had other types of property, primarily on the alpha-2 adrenoreceptor, could also promote brain health. This is just a summary of the findings that were obtained in the audiogenic seizure mice model, DBA1, DBA2 mice, using different types of monoaminergic drugs, either tackling the serotonin pathway or the norepinephrine pathway. And I'm not going to go into the detail here. Now, moving to which type of endpoint we might look at. I will say that ideally, considering the level of uncertainty we do have regarding the potential impact of all those interventions, we would rather start with surrogate biomarker. But it will need to be modifiable biomarker in the first place. Other biomarker or predictor of SUDEP, like a gene mutation or a brainstem atrophy on MRI, are unlikely to be changed by treatment, including treatment that will prove effective on SUDEP. So those are not of great interest in terms of surrogate biomarker. And when thinking of which biomarker could be truly modifiable and be really predictive of the cascade of events leading to SUDEP, we have to acknowledge that none have been seriously validated so far. Of course, there are reports that SUDEP patients, when compared to control, have shown changes and abnormality in heart rate variability, have shown postictal EEG suppression, and so forth. But Again, we need to acknowledge that none of those biomarkers has been validated in a way that will make them relevant today for a surrogate biomarker of a randomized controlled trial for testing an Anti-Sudep treatment. And that's why I think we're kind of stuck at the moment if we want to test an intervention to go directly for Sudep incidence. But here we face a major issue, sample size. We'll discuss sample size in a minute. What about the population we need to test? I think it's important that we consider the likely heterogeneity of Sudep pathophysiology. Most Sudep are related to a GTCS, but not all of them. And definitely, it's likely that we'll face differences between genetic and non-genetic epilepsy, and especially genetic epilepsy in relation to clear-cut gene mutation, like in Dravet syndrome, or like in epileptic condition and epileptic encephalopathy that include a cardiac channelopathy. We also need to recruit patients at really high risk of Sudep. In the first place, because persons who have an average risk of suffering a Sudep around 1 per 1,000 patient year are really unlikely to be motivated to participate in such trial. But also because this is the best way to reduce sample size, which is the major issue we're facing. This is a scale of the issue. If we consider a standard parallel group randomized controlled trial, that will need to last 1 full year, which is a very long duration for a double-blind RCT. And if we consider the current risk of Sudep in patients with uncontrolled epilepsy, which is about 4 per 1,000 patient a year, or 0.4%, if your hypothesis is that the intervention will reduce by half this risk, you need to recruit more than 30,000 patients. Clearly infeasible. If you're more optimistic that your intervention will reduce the risk by 80%, we still need to recruit about 10,000 patients. Very challenging. Now, of course, if we're able to recruit patients at high risk, and imagine there will be a population with that risk will be up to 4 persons per year. I'm not sure that such population exists, by the way. But let's assume it exists. Then, of course, it will reduce by tenfold the sample size. Now, what are the different populations which are available for study and where the risk of Sudep will be the highest? As I mentioned, in most cohort of uncontrolled epilepsy, the typical risk is about 0.4%. There has been one single outlier study where it was 1%, but it was an old small-scale study in patients who had failed epilepsy surgery or were still under evaluation, and those findings were never truly reproduced. So I think we need to consider that 1% are the true outlier and consider, again, that the general figure of Sudep risk in patients with refractory epilepsy is rather 0.4%. So how can we get to higher figure? Well, by considering the main risk factor of Sudep on top of having a refractory epilepsy. And we know that the main one is, of course, for suffering from GTCS in the last year or several GTCS in the last year. All reports, all case control study agree on that main finding. We'll discuss its impact in a minute. But can we go further? Can we increase the selection of patients at higher risk by including other criteria, other variables and predictor than just refractory epilepsy and suffering from GTCS? Well, that's exactly what has been looked at in that recent personalized prediction tool that has been developed using the same 4-case control study that we used by Deleuze-Dorfer 10 years ago to delete the main risk factor of Sudep. And here they use a state-of-the-art regression model and incorporate up to 29 different variables to establish the most predictive model. And indeed, they could achieve a model that is more predictive than using GTCS alone. But even though the difference is significant between the two, I guess you will agree with me that the difference in the performance of the model, in particular for the internal validation, it's greater for the external validation. But for the internal validation, the difference is really marginal. From a NOROC of 0.69 to 0.72, you can guess that the capacity to translate into truly higher risk of SUDEP will be limited. Now, the recent nationwide Swedish case control study, which I've been praising for its quality, is bringing in another important element on top of GTCS. It's whether the patient are living alone or sleeping alone. And when combining the two variables, suffering from GTCS on the one hand and not sharing bedroom or not sharing household, you get very high odds ratio when considering patient with GTCS not sharing bedroom. How do they translate in SUDEP risk? The odds ratio is one thing, but what we're interested in is a SUDEP risk. Well, you cannot calculate this directly from the case control study by definition. But because that case control study was nationwide and the same group, that of Torbjörn Thompson, also published on SUDEP incidence at the national level, I think it's fair to perform the types of calculation I've been doing, which is an extrapolation, so we need to be cautious, but it's fair to make that extrapolation to estimate the SUDEP risk in the different group of patients according as to whether they suffer from GTCS, at least one in the last year or at least 4 in the last year, and whether they share household or not. Okay, in Sweden, we have 10 million inhabitants with a 0.6% prevalence of epilepsy like everywhere else. So it's 60,000 patients living with epilepsy. And let's say we consider those patients not sharing household and having at least one GTCS in the last year, they do represent 9% of that population. So it's a significant pool of about 5,000 patients. But then if we look at what will be the SUDEP risk, we find out that it's twice higher than the general SUDEP risk in refractory patient. It's about 0.8% rather than 0.4%. It's still below 1%. Which means that if we come back to our sample size issue, basically we will need to recruit probably between 4,000 and more likely 5,000 patients to achieve such a study. 5,000 will correspond to the entire person with epilepsy suffering from a GTCS in the last year and not sharing household in the entire country. Clearly not feasible at the level of Sweden only. But now, let's say we use a figure in the US and assume they will be comparable. Maybe they're not. We will have about 170,000 persons with epilepsy who will have suffered GTCS in the last year and not sharing household. We know from the National Association of Epilepsy Center in the US that no more than 20% of those patients with refractory epilepsy are being followed at epilepsy center. And this is the only place where they can be recruited, or the primary place where they can be recruited. And I think it's also fair to consider that probably less than 1/3 of those patients will be interested in participating in such a trial. At best, that leaves us with 10,000 eligible patients in the US overall, and we will need to recruit half of them. Quite challenging, and again, I will agree with you saying it's not really feasible. And that leads us to the last question, the trial design. Considering those major challenges, but also the rationale and the importance to be able to move forward in that field and eventually prevent that tragic, unacceptable outcome in person with epilepsy? Well, the solution to me is the so-called adaptive platform trial. I'm sure many of you have heard of this organization and its potential benefit. I don't have the time to go into the detail, but let's just summarize my view is that through adaptive platform trial, we could definitely engage a very large number of centers and country to achieve the needed sample size. We could test multiple intervention of interest in a reasonable time frame. At the moment, what I described will be for one trial only, and we have no clue to prioritize the different intervention that I've been mentioning. We could use that platform to tackle in parallel and synergistically other very important epilepsy therapy issues, whether it's for anti-epileptic treatment that are believed to have an anti-Sudep property or anti-Sudep treatment that might have an anti-seizure impact. And I'm thinking of epilepsy surgery, treatment of epilepsy comorbidities, rare disease in epilepsy. And again, those adaptive platform trials also offer novel opportunity for funding on top of the classical, let's say, NIH-sponsored trial. So, in conclusion, I do strongly believe we need to test intervention to prevent SUDEP, inasmuch as we have a strong enough rationale for various intervention, safe intervention, for most of them. The main limiting issue is the lack of validated biomarker and the required sample size to perform such clinical trial. And I do strongly believe that an adaptive platform trial could enable us to tackle those issues. On that, I'd like to close my lecture and thank you very much for your attendance.
Thank you very much, and thank you to all our speakers. Is it possible to bring Dr. Ryvlin and Dr. Parks-Browne up on the screens? We're going to attempt some sort of virtual, in-person, hybrid panel discussion. Dr. Ryvlin, can you hear us and say something, prove you're there? Yes, thank you for nodding. And do we have Dr. Parks-Browne as well? Yeah, we do. Oh, wow, you're both there. This is great. Thank you so much. Really appreciate you joining us, albeit virtually. So I'm opening it up to questions, discussion. I have a few things that we can get us started if there's no one from the crowd. We have people with microphones. Yeah, sure. Yes, please, go ahead.
My question is to the panel and the doctors on Zoom. The day that we actually lost our son, we as Black minorities are being accused of causing harm to our loved ones. When the police and paramedics came into our home, it quickly turned into a homicide scene. You can only imagine how one may feel that you have just lost your child, but how quickly it actually changes into a homicide scene. My question is, where can we go from here to address this issue? Because it's not just our family that's enduring this, it's many others that I have come across that face the very same things. My next question also is, we know that there is a great underreporting when it comes to SUDEP. Mm-hmm. We know that there's a gross amount of undercounts. What we're finding out is on these death reports is that it's being put as coronary pulmonary arrest. I have also addressed this issue. The answer that I was given was, well, it's the same. No, it's not. In order for you guys to be able to get the right research at the right time to help come into the forefront of a cure It has to be reported correctly, first and foremost. So I'm going to turn these questions back over to you in hopes that as of today, everyone who's sitting on Zoom, everyone who is on the panel, every doctor, every researcher, every parent, every caregiver in this room, pay attention to what is going on behind the scenes. We all have an accountability. And if we don't take accountability, the research and the time and the effort that PAME, Danny did, AES is actually taking, we will never come to a forefront of a cure. We have to be acclimated in order to push those who write on these death certificates the right thing, so that the monies can go into SUDEP research and not into cardiology and not into pulmonary research. We have to start today. We have to take accountability, and we have to stand fast and stand firm.
Thank you so much. I thank you for your comments, and there's been some comments in the chat as well around the police investigation issue, and I've heard that from other families. I know other people have heard it from families as well. I would like to direct some of your question towards Dr. Parks-Browne, because I'm wondering about, I think it's related to what the relationship is when you're running a registry like you do with the death investigation folks, and whether you're able to create some learning curve there or something around how we treat families and how we report cases. Do you want to address that?
Yes, absolutely. Thank you, Elizabeth. And I wish I could see the person from the audience. I wanted to thank you for that comment as well. But yes, this is an area we have encountered a lot, working with SUID as well. Same scenario, these parents have lost their baby, and the responders come in and they take the baby and they lock it down as a crime scene, and what could be more traumatic than that. And not just traumatic, but it's also counterproductive in really getting the information that's needed to find out what truly happened with the child. But along those lines, we have done a lot of work with our registry in terms of partnering with the medical legal investigation centers. So it's really having our awardees work directly with the death investigators in their jurisdictions to train them on, how best to go about collecting the information that's needed on the scene when they're responding to the scene. Same thing with the medical examiners and pathologists. What's the best way to approach families when you're doing a witness interview, when you're doing a family interview, and just being sensitive to the needs of families and trying to balance, trying to get objective data with, the fact that families have just lost a child. We're also really working more recently around addressing health equity and being sensitive to racial and socioeconomic and other disparities. So what that looks like, not just ensuring that we're getting accurate representation in our data, but going further to say, how are those factors and how is unconscious bias playing into how investigators are responding on the scene and what types of questions they're asking. So those are all areas we're trying to push the issue with. And then in terms of how, I guess, the death certification and the causes that are being listed on death certificates is a huge problem. We've made huge strides in trying to standardize that for SUID. And so this is another area that I'm hoping, we can start pushing the envelope with SDY overall and SUDEP in particular. We've got work to do, but we have a good model for how to try to address it.
Thank you. I think that's a hopeful answer as we see the benefit of registries. I think we need to keep pushing for that kind of work to happen. Laura, right?
Hi, yes. It's on.
Introduce yourself, actually, because people can't see, the folks there can't see you.
Absolutely. So I'm Laura Lubbers. I'm with Cure Epilepsy. And I want to thank Tanisha once again for bringing these issues forward in a very pointed way. I think we all need to hear it. So thank you for sharing your story. It's incredibly valuable. This question is also for Commander Parks-Browne. As an advocacy organization representing, and many advocacy organizations are here with us today, what can we do to help advocate for more STY research, the registry? Are there things that we could do at the federal level, the state level? It is incredibly encouraging to see the growth that's happening with the registry. It's remarkable to see its growth. But clearly we're not even covering half the states. So what can we do?
Also a great question. Thank you for raising that. And I can say as a Fed, we're unable to do any lobbying, but we always appreciate and value the power of our partners who are able to do that. One example I have of kind of successful lobbying has been from our colleagues at the Microsoft, the Seattle SIDS Center, and they've partnered with Microsoft, and they've been a powerful force in advocating for additional funding for SIDS research. And I can say that their efforts have, I think, I can't say directly, but I'm sure they had a major role in there being some additional congressional funds put towards SIDS research in this most recent budget. So as much as you can, just keep pounding the pavement and getting the word out there about the need for more research and more resources to help address mortality, epilepsy-related mortality, the better. I think it's just having that constant pressure and that constant presence so that we can't be ignored. We definitely appreciate that work from your perspective.
Well, in my experience with CURE, if CURE wants to see something get done, it usually gets done. So just advocacy, advocacy, advocacy. Thank you for that. There is a question in the chat. Is that what you were going to say?
Yeah, so go ahead.
From Sally Schaefer, who, it's a question actually for you, Dr. Grinspan. You mentioned that the next steps were to reach out for death certificates. And so she's wondering if we know the percentage of inaccuracies about death certificates. So there's actually a lot of discussion around death certificates and how we kind of classify things. So can you comment at all on that? And then I actually have a bit of a follow-up on it as well. Mic on over here, please. Thank you.
Question. I don't know the direct answer. For our initiative, part of what we want to do is sort of understand for ourselves how well the information from the NDI correlates with what we're seeing in the electronic chart to understand to sort of give another angle to understand how reliable these different sources of data are to get a handle on mortality.
Yeah, and the whole kind of death certificate, death reporting thing is a very big issue. We've been working on it for a while. In my own jurisdiction, we actually did a study where we looked at the results of autopsies, and then we reviewed, and the final kind of word on what they called the cause of death, and then we reviewed them as Sudep researchers, and similar work was done. I see Dan at the back, Dan Friedman at the back, similar work was done by him and his group. And we actually found that there was a decent correlation between how a death was classified, when a death was classified as Sudep, if you included things like deaths due to Sudep, death due to epilepsy, death due to seizure, that there's pretty good correlation with what a forensic pathologist would classify the death as. But it did require a fair bit of work by a very experienced Sudep researcher to kind of look into those deaths. So it actually led me to wonder about the cases, I think it was in Dr. Parks-Browne's data where there was, because in the data that Vicki Whittemore presented, she noted that the incidence in kids, and this is my area, where I study kids, is that the incidence with kids was lower than what we've seen in some other areas. And I was just wondering if some of the explained cases, if they had been looked at by through a certain lens, if any of those explained cases were also individuals who had epilepsy, and that they might have been reclassified in that case. I don't know if that's totally clear. And you might not have that numbers in front of you, and that's okay, but I think it just kind of highlights that we need to look at all these cases very carefully to get to classifications.
Yeah, I don't have the numbers in front of me, but I think some of the group that we had that explained other group includes cases that were explained neurologic causes. So there may be some of the epilepsy-related deaths represented in that group as well. Does that answer the question?
Thank you. I don't know if anybody else wants to comment on death certificate reporting. Otherwise, any other questions? Yes. Please introduce yourself, Madison.
Hi, I'm Madison Burrow. I'm a neuropsychologist from Children's National in DC. So I'm going to push you, Dr. Grinspan, but it's out of love, and I know you can handle it.
Oh.
So you had the comment in your data that really to do a debrief and understand post-mortem what's going on. There was a concern from the physicians to do on their individual cases. But we would agree that because there's so much variability, to collect that in aggregate is not as powerful as if you did it, right? So we've done difficult research for a long time. We ask drug users, they don't want to admit to doing something illegal, and we do research that way. Can we not rethink our methods to still get on an individual basis and de-identify and aggregate backwards so that we can get that really crucial information? Because it's also the doctor's thinking that is so critical. Everybody can espouse on somebody else's cases, but when you really go back and you know that kid, and that's where we learn the most, in my experience, when we do those post reviews. Could we not do a little better?
Dr. Burrell, thank you. Dr. Burrell, thank you for that question, I appreciate the opportunity to sort of be pushed and prodded. It's how we move forward together. So thank you for that. You're absolutely right. As we conceptualized the project, that's what we were after. We wanted that moment of I'm looking at the chart and I'm like, oh man, we should have done X, we should have done Y. So we know that that's there. And then I think at the heart of your question is like, well, how do we get at that in a way that's going to, where we're going to get sort of truthful answers from the physicians, we're going to be able to make sense of it and aggregate it. Our initial idea was like, oh, we'll just have them like click on the red cap form, and there was pushback, and so as a leader of an initiative like this, you have to sort of listen to that, and so we did, and for this round we'll collect it in the aggregate. So I'll now just sort of think out loud with you, like how would we get it? It feels really qualitative, right? Like maybe you need to do interviews and sort of have a protected space. Maybe we don't do a lot of morbidity and mortality sessions in neurology. They happen from time to time at our center. That some years we have it, some years we don't. So do we need to bring that back and make it more formal? Sort of bring that back to our culture. So I don't have a direct answer for you other than to say that it's important and that we should keep thinking about this together.
Thank you. I'm going to, while we get a mic over to you, because I see someone has a hand there, in the meantime, I'm going to, since Madison was poking and prodding you a bit, Zach, I'm going to poke and prod Philippe a bit, and really try and nail home what you think, Philippe, are the next steps for planning intervention trials. And your talk was excellent and provocative as well. But are we at a point where we should be doing something like this? I know one of the things that has been tossed around in the past is the idea of like a population-based intervention, where then we could actually use things like what Sharyn and Zach do, electronic health records or registries to monitor for change with some population-based intervention. I don't know what that population-based intervention is. Maybe it's increased funding for surgery, right? But where are we? What should we really do next?
Well, again, that was the main point I want to raise. On the one hand, do you hear me?
Yes, although I'd ask the AV people to turn up your volume a little.
On the one hand, I'd really like to stress that we do have strong hypotheses to test, and it's a shame to wait for testing them. And that has been the case for a few years now, because I think those hypotheses were strong enough already some years ago. But to organize such intervention study, whatever the framework, whether it's a classical randomized controlled trial or whether we use a more flexible or more agile framework, we need to organize it. We need to have the appropriate platform, and we need some fun. This cannot be done with specific funding. This cannot be done by just exploring electronic health record. There's need to be a planification. That's the bottom line of testing and intervention. You need to have a control on the way things are being prospectively collected. And so, that's where we need to be smart and work together to decide what should be that framework. My main conclusion here will be the following. I think, most people participating to that meeting, all of them are good, willing people, devoted to help, whether it's clinical research, basic research, lay association who support that research. That's very good, but we need to get to a high level of partnership. In the direction, the roadmap that the PAME organization have been showing for the beginning, but it needs to get to a higher stage of partnership in the same way it has been done in other conditions, in the field of cancer, in the field of stroke in neurology. Adaptive platform trial, that's a beautiful one that has been set up for glioblastoma research.
Okay.
And I think that's really what we need to do. A way to say it, I'm sorry if it sounds too emphatic, but that in response to the first comment we had tonight, SUDEP is a huge challenge. We have other in the society. Racism has been mentioned, climate change, and the only way we can tackle those challenges is not by just being good people doing what we think is appropriate in our own university or hospital. We need to work together in a different way, in a more sharing way. The last one I want to say, because it happened in France this week, and it kind of get together all those issues. We offered Josephine Becker, I hope most of you know her, a place in the Panthéon, which is the most important place where you can be buried in France. And, that reflects what that unique person did. By first being a performer, coming from Missouri, a very small and poor area, and becoming one of the most famous performers in the 30s and 40s, and then becoming one of the main resistance in the Second World War in Europe, and finally being just after Martin Luther King, when he gave his beautiful lecture about his dreams. And so, how a person can go to that unique level of helping others. Of course, we cannot do what she did, none of us, but we can take an example to learn how to be more sharing with our peers, with our colleagues. That's the only way we'll be able to set up that framework for testing intervention rapidly.
Thank you. I think that's a good call to arms from across the ocean, and I'm really grateful for that. And with that, I'm going to actually, you're telling me to wrap up, and you're telling me you have a question. No? No, I think we're good. It's lunchtime. I want to really, really, really thank my speakers and the audience for participating. Great to have you join us virtually. Thank you for your patience with a virtual mixed platform. It's time for lunch. Thank you very much.